Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms, Marcus at Home welcomes Dr. Fernando Fervenza in Rochester, Minnesota, with whom we would like to discuss the pathophysiology, the diagnosis and treatment of membranous nephropathy. So Dr. Fervenza is a leading expert in the field, and he's the one who introduced innovative treatment into the field and published several New England papers on this topic. My co-moderators today are Dr. Sarah Morel at the Atlantic Coast in France and Paul Diefenhardt in Cologne, Germany. My name is Gunnar Heine from Frankfurt, Germany.
Dr. Fervenza, if I may, I would start with a few questions, just general questions on the pathogenesis of the disease. There have been quite a few advances, I would say, in the last 2 decades in our understanding of what is going on in the kidney of a membranous nephropathy patient. Could you give us just a general overview of what we know about the disease? What is happening in the kidney?
Well, I think membranous nephropathy is an area where there is I would say the field of glomerular disease has been a blessed field in the last 10 years. Because when I came into nephrology, everyone was trying to do, it was transplantation, that was the story, and then dialysis, and there was nothing for glomerular disease. So nobody really wanted, because glomerular disease, what you would do at that time? You would just give steroids, and you do not know nothing. And lucky in the last 20, or even in the membranous nephropathy, last 10 years, has been a complete revolution. Because now from historically that in membranous nephropathy you say, well, this is an antibody-mediated disease but there was all theoretically until the first confirmation came when Pierre Ronco demonstrated those child who had deficiency antibodies against NEPT, neutral endopeptidase, and that it was antibody crossed the placenta because the mother was became immunized with the NEPT from the child or the first pregnancy, and then the second, and cause neonatal membranous nephropathy. Of course, the child became good once they were out of the uterine environment. But then, of course, that was rare, these cases, but until 2009, when the fundamental study by David Salan and Larry Beck then found antibodies against PLA2R receptor, PLA2 receptor, that explain how the disease would develop in the next, in about 70% of the patients. But of course, there was still 30% of the patients left. And then a few years later, then again, Larry Beck and Rolf Stoll and Lambeau, they found antithrombospondin 7A, and that was a new revolution. But of course, antithrombospondin accounts for what, 1 to 3% of the patients who are PLA of the membranous nephropathy. Still, there was an knowledge. And then suddenly, in the last 2 years, starting here with at Mayo with Sanjay Sethi, discovering the exostocin 1 and 2 in patients who have autoimmune associated membranous nephropathy. And then that was followed by Sanjeev, we were collaborating with Pierre Ronco in Paris about NEL1. And then this was followed by semaphorin 3B, and then by protocadherin. And most recently, Larry Beck described another one about HTP1 or something like that, antibody. And there is, I was informed, it's not on PubMed yet, but if you go to the Lancet, I think on the articles in press, there is another which associated with a neurological condition. And suddenly there is from 10 years ago knowing nothing to like just 11 years later, we have at least 8, 9 antigens So now we are starting to be able to point and say, well, you have a PLA2R associated membranous nephropathy, you have a NEL1 associated membranous, and so on. So this has entirely unraveled. And not only for the diagnosis, but a lot of PLA2R, and to me, there is no reason why I not believe that thrombospondin C is not the same. To use this antibody not only as diagnostic, but to follow therapy, in response to therapy, prognosis, all these things. So it has been a revolution. So now all the great news are in glomerular disease in nephrology, because transplantation is nothing new. It has nothing new in the last 10 years, and it's not going to have anything new in the next 10 years, because when you get survival rate of 98%, what are you going to make it better in the first year? You're not going to do that. In dialysis, unless they create an automatic kidney machine, and is going to come from their idea, right? So all the action is in glomerular disease, where we have now markers of the disease, not only diagnostic, but therapeutic, and the colossal amount of armamentarium. I think Gunnar, I'd like to point out, because he mentioned that I made contribution to the treatment. I have to say that I follow, because when we go to talk about rituximab, the fundamental discovery was first historically was by Ponticelli with his prednisone cyclophosphamide regime. But in the modern era is what with Beck and Ramuzzi, because Ramuzzi was the first one to introduce the use of rituximab to treat patients with membranous nephropathy. And of course, we just follow after.
Right. Maybe one more question, if that's known at all. People start to develop, to produce antibodies against these antigens. Do we know if there are any triggers that trigger this antibody production? Is it environmentally triggered, or are there sort of infections similar to what we see in IgA nephropathy?
I don't know. I mean, there is, in fact, some years ago, there was, I think, an editorial by David Saland, where he talks about the perfect storm. And at least in PLA2R, we know that is genetic factors that predispose but do not explain in total, because a lot of people who predispose in never develop membranous nephropathy. But there's probably some predisposing, some genetic background. I would say probably is the background of the painting, and then likely some environment, some infections. Who knows what triggered? The curiosity is also, why does membranous nephropathy? I mean, if everything is good, whatever, but why is this only affect like adults? Why this disease doesn't start with children, whatever. So I don't. It's probably. I think Salant talk about the perfect storm. You have to get probably the genetic, the environmental, and probably the infection, whatever the triggers that development of the disease.
Maybe one last question before we go on to the clinical aspects. There are certain findings we usually see in biopsies if we do biopsy in membranous nephropathy. Could you just sum up which immunofluorescent staining we usually would see and which pattern? Is the typical ones for primary membranous? Yeah.
So for patients with like PLA2R or Thrombospondin or NEL1, the characteristic is you have IgG and C3 deposition. All right. So, and I think depending on who you talk, which pathologists you talk, I mean, probably they're going to say this is the early findings. Is going to be the immunofluorescence. All right. So with IgG and C3. And this is basically all of the membranous nephropathy, with exception with the newly described semaphorin 3 that Sanjeev described, that's more common in children. This characteristically, these patients, the C3 is very weak, or non, just so the patients have IgG, And of course, the electron microscopy will show the deposits, but the C3 is very, so this is a clue, if I may say, that this maybe is in a child who has very weak or absent of C3, the IgG deposit, that is a semaphorin 3B antibody or semaphorin 3 associated membranous nephropathy. So, but apart from that, the IgG, now, of course, if you want to do subtypes, you can do subtypes. Then, of course, the PLA2R is going to be more IgG4 predominant, while NEL1 and semaphorin, for example, I see IgG1. But I think in the past, this was important to do these subtypes. I think today with the availability of the stainings, I mean, you can stain for thrombospondin, you stain for NEL1, you can stain for semaphorin. So the subtype is really very little to me, right, in clinical relevance, because you can just go and stain for the antigen anyway.
So if it's okay with you, I would like to move on to some clinical aspects. So symptoms in membranous nephropathy are quite various. Some patients have none at all, and other ones have a full-on nephrotic syndrome. So when would you consider membranous nephropathy, in such a patient?
Well, that's a very good question, because I think you are right. I mean, there are some patients, I would say the majority of the patients present with a full-blown nephrotic syndrome. Fine as a proteinuria more than 3.5 grams per 24 hours and a serum albumin. Depends on where you are. If you are in Minnesota, we decide that it's less than 3.5. If you are in the Netherlands, they decide that it has to be less than 3 because of different methodology used, right? But in usually those patients present with large amount of protein edema, right, hypoalbuminemia. But you are right, there is a small group of patients, I would say small, that they have a little bit of protein, they have like 1 gram, 2 grams of protein, and gradually they develop more proteinuria, or stay with their little c. So I would say that any patient that presents with proteinuria, especially if it's an adult, and you have to consider that they may have membranous nephropathy. It's the most common cause of, especially if they are nephrotic syndrome, if they are white, is the most common cause of membranous nephropathy in the world.
So, as you've said, the discovery of the anti-PLA2R antibodies is quite revolutionary. Let's say a patient comes to you with a nephrotic syndrome and positive anti-PLA2R antibodies. Would you, is that sufficient information, or do we need any more diagnostic workup in order to diagnose membranous nephropathy?
Again, this is an excellent question. So I do believe that you should be thorough. I mean, I do believe that you should do a thorough evaluation in any patient that comes with proteinuria, right? And what do I mean by a thorough evaluation? So at least at Mayo, when a patient comes to Mayo, I have a panel of patients with Recurrence disease. And it includes a CTC, includes a full chem panel that includes a serum albumin. You cannot do glomerular disease without knowing serum albumin. That's crucial, because to answer the patient nephrotic or non-nephrotic, believe me, a lot of people don't check serum albumin. A lot of studies haven't checked serum albumin. A lot of programs that are funded by distinguished federal agencies don't even require albumin to be checked, which is a colossal amount of ignorance, all right? So you have to have albumin, you have to have a liver function. And then you have to have the hepatitis serology. You have to have complement. You have to have anti-double-stranded DNA. You have to have ANA. You have to have the hepatitis serology. And you have to have the monoclonal protein. And you have to have 24 urinalysis and a 24-hour urine protein for proteinuria and creatinine clearance. I am old-fashioned. I like creatinine clearance. I don't really like estimated GFR. All right, to me, creatinine clearance tell you a better picture of how the kidneys work. Doesn't matter if creatinine clearance also is associated with a little bit of tubular function. So what? That is how the total of the kidney. Doesn't matter. It's like asking you in the account how many thousand euros do you have in account in total, and you say, well, I have 100,000 euros. Ah, yes, but in your current account you have 80,000. In your savings you have 20. Doesn't matter. You know, the end point is that you have 100,000 euros. All right, that is that counts. So not so that's to me what they count. And of course, at Mayo, since the advent that we could start measuring PLA2R antibodies, all right. So every patient get proteinuria, get a PLA2R, right? And frankly, I mean, you may say, well, this is it's more expensive. You are making a lot of it. It doesn't care, all right. I think you should treat persons as you are in the first-rate institution, and the cost should be of very little consideration about this. So if you do that, then of course some of these patients will be PLA2R positive. Also, every patient that I see gets a chest X-ray, all right? Because I see it's part of the physical exam. Now, if the patient is PLA2R positive, and we published this a couple of years ago, all right? Then we look and said, of course, the PSO is the likely that is going to be membranous nephropathy because the antibody is very specific, right? So if the patient is at 30 years old, all right, and it has no one in the hemoglobin is normal, I'm not going to start doing colonoscopy because this patient is not going to have colon cancer, right? But certainly ultrasound to see the kidney, I'm going to look about if there is kidney size and if they have a hypernephrom, whatever. If the patient is not a smoker, a chest X-ray is sufficient. If the patient has a long history of smoking, then you do a CT. If he's a man greater than 40 years old, then I think PSA you should do, a woman a pap smear. But if all this is negative, which is in the vast majority they are, all right, and you have a PLA2R positive, this to me is membranous nephropathy. You don't need to do a biopsy, provided the patient has normal kidney function. All right.
Okay.
And that you look. So in a lot of, but remember the most dogmatic. All right. I think I have in my office here. Yes, it's from I think it's from Gabriel Richer, was the main mentor from Pierre Ronco. And it says here, the main obstacle to medical progress is dogma. And physicians are dogmatic, so they create this. And so a lot, there is a school that, oh, they want to biopsy everybody. And you explain to it, you ask them, but why do you want to biopsy? Oh, because it's a prognostic. But I said, but what prognostic? If a patient has a creatinine of 1, which or normal kidney function, which the majority, 2/3 of the patient with membranous nephropathy will have, what prognostic factor are you going to find? Nobody can show. Oh, but the patient may have a superimposed vasculitis. Oh, yeah. And so, and you think that he will present with a superimposed vasculitis with a creatinine of 0.9. Oh, well, nobody may have interstitial nephritis. Oh, interstitial nephritis without a history of a drug exposure, right? So this patient has no history of anything like that. And again, present with interstitial nephritis so severe that the creatinine is normal. So, but it's dogma. So we presented this, and it's such a dogma because then when you confront, all right. So when you we published this in Kidney International. In patients, we have normal, meaning estimated GFR greater than 60, and that we have gone toward those lists, and there's nothing. There is no cancer, no drug, no hepatitis, no autoimmunity for whatever. The biopsy in 100% was membranous nephropathy and nothing else. All right. So I said the dogma is like that because in children, all right, we've been brought up that if a child presents with nephrotic syndrome, in principle, is minimal change, you don't biopsy. You go there and treat this patient. And nobody questioned, all right, that in 80%, all right, But in membranous, when you give evidence that the result is 100%, people are still questioning because it's dogmatic. We have been educated that we have to biopsy. And until you do the click and say, look, for this group of patients, you don't need to biopsy. Of course, if the patient has a normal EGFR, or if the patient is another way diabetes, all right, you have to biopsy this patient because you cannot really, if the patient has a EGFR less than 60, well, then he may have other things other than membranous nephropathy there. And in fact, in that study we did, and we are doing now, is under review. We submitted a manuscript. We collaborate with Andrew Bombach from Columbia in New York and with Dr. Maria Jose Soler from Barcelona. So we collected over 100 patients there. But I bet you that is the same business. At Columbia and in Barcelona is the same story. If you have a EGFR greater than 60, you do all this secondary negative, you do a biopsy, there is nothing else than membranous nephropathy. But I bet this is still the group of the biopsy. They are still going to continue by. They will still, oh no, it's still going. What can I do? You know, you have to do whatever you want to do. You know? But that is the story. It takes time but stay time is a lot of things. I have patients, I mean, because of the dogma or also because of how we evolve, I have patients here that come to Mayo that have been looked by other nephrologists and membranous nephropathy, and the patient has had a diagnosis for a year. And then I talked to the nephrologist and I said, what is the PLA2R of this patient? And the nephrologist said, oh, I didn't order. So here you have it, right? So we are 10 years, 11 years since Larry Beck discovered PLA2R. And there is still patients around, walking around with diagnosis of membranous nephropathy, and nobody has bothered to order an anti-PLA2R antibody. So it takes time to filter all this knowledge.
Thank you. A very last question would be the role of the newer antibodies, as you've said before, such as NEL1 or THSD7A. Should we be looking for those antibodies if a patient is negative for PLA2R?
I think we should. Now, the problem is that we don't have with exception, Euroimmune has immunofluorescence assay for thrombospondin 7A. But there is no commercially available one for NEL1 or for procalcitonin. But I think it's just a question of time that those assays will become available. Then we will have a much more individualized medicine. But this is a question of time, I think. It's just time. There's no question. We know the antibody exists. I mean, when we published with Ronco and the NEL1 and the procalcitonin, the antibody is there. They just need a company that was interested to create an ELISA and start commercially being available.
Thank you.
So we would switch to treatment. Julie, we would like to discuss mentor, but firstly comes supportive treatment. So surely we would go for ACE inhibitors. Surely we would go for low salt diet. What else should we recommend to our patients? Do you give aldosterone receptor blockers to these people regularly?
So that is the story. So no question that if you have a patient who have nephrotic syndrome, all right, so you are trying to maximize everything that can reduce proteinuria. Patients who are nephrotic syndrome, they have a great affinity. The kidney is very avid for salt. Any salt that appears in that kidney is sucked, all right? Such that a patient with nephrotic syndrome, I teach my I was in the hospital. I'm in the hospital service this week, and I was there this morning. So a patient that nephrotic, no bother to you order a urinary sodium because it's always going to be less than 10 unless this patient has acute tubular necrosis, right? Because the kidney is so. So the first thing you put is the patient in a salt restriction. You put them on a low protein diet, not because the protein is going to do any, but it's because if the more protein you eat, the more proteinuria they're going to pee. And it doesn't, and for whatever reason, if you restrict, in fact, you help increase the serum output. And you put the patients on a ACE inhibitor. Well, you try to control the cholesterol, but unless you control the nephrotic syndrome, forget it, you are not going to control the hyperlipidemia. And you put those patients on ACE inhibitor and ARB. Now, this has been grossly, the ACE inhibitor and IRB has been grossly misrepresented, especially because a lot of people that recommend, especially if you study sections of those great funding institutions, these are experts that in majority of time, the patients that they see have 4 legs and a tail, all right? So they don't really see, and then they believe the ACE inhibitors are going to reduce proteinuria and in a great deal. But ACE inhibitors, in fact, are very poor antiproteinuric agents, all right? So you say, but Fervenza is a fool. You say that ACE inhibitors are not the proteinuria. Yeah, well, it's true. Because the ACE inhibitors, remember, they were great. Where did they came from? They came from studies in diabetic nephropathy, right? But I tell you, which is diabetic nephropathy patient that you know that is normotensive? All diabetic nephropathy are hypertensive, not only hypertensive, they are severely hypertensive, and usually they have 2, 3, 4. So because ACE inhibitors are very powerful antihypertensive medications, of course they control the blood pressure, and of course they reduce proteinuria. So, but a lot of the reduction in proteinuria comes from control of hypertension. Now, when we go to the membranous nephropathy business, the majority of those patients, 80% of those patients, are normotensive, all right? Then you put those patients with a young guy or a 40 years old with membranous nephropathy, and then he comes to you, his blood pressure is 115 millimeters of mercury systolic. You put him on 10 milligrams of lisinopril. And a week later, he comes and blood pressure is 100 systolic. And the patient tells that he's very difficult. He likes to go jogging, but he feels dizzy if he goes jogging. And you say, oh, and you see the proteinuria that was 10 grams before, and now you measure again, and the proteinuria is 9 grams. No, it's because I haven't used enough ACE inhibitor. I'm going to increase the ACE inhibitor more. And then you put to 20. And a month later, the patient just come in a wheelchair because he is unable to walk because his systolic blood pressure is 990, and you look at the proteinuria and it's 8.5. A great deal. You reduce for 10. And this has been historic. Beppe Ramuzzi, again, did a study, showed a study years ago, and they showed that if you put those, the maximum reduction in proteinuria is about 25-30%. Brian Myers at Stanford did also this years ago, so it's exactly the same. So what I'm trying to say is the following. In a primary podocytopathy, like membranous nephropathy or FSGS, primary FSGS, the ACE inhibitors, we use because we have to follow, and of course they have some antiproteinuric effect, but it's trivial because you have a reduction of 25-30%. Now, if you have a patient with diabetic nephropathy that has a proteinuria of 4 grams, and you control the blood pressure, and you reduce that proteinuria from 4 to 2, then it's a major, all right? But if you have a patient with full nephrotic syndrome, membranous nephropathy, he has with 14 grams of proteinuria, and you reduce the proteinuria by 30%, so you reduce for 14 to 11. Great deal. Tell me, in what are you really achieving? All right, not much. So yes, we do that. Now, if the patient has a low degree of proteinuria, then the effect is much more marked. But if in the full nephrotic, in fact, a lot of people say, well, what about to do dual blockade? And we tried this. We published this years ago with Dan Catran. We did a pilot study on rituximab, our second study on rituximab. And we tried because we were worried that we were going to send to journals, and obscure journals have a lot of reviewers, and most of the reviewers are authorities who sit in study sections. And again, they have no clue about clinical patients, but they know about the rat. So they will come with this, but have you used dual blockade? And because at that time, maybe, so we put in the protocol that we are going to give maximum ACE inhibitor. And after that, we would add an ARB. Well, we recruited 20 patients, and it was impossible to recruit to add the IRB because by we maximize the ACE inhibitor, they were all hypotensive already. So I think we wanted to add a little bit of A2 blocker on top of the ACE inhibitor in about 3 patients of the 20, showing that the idea is very good, but in practice, because they are not hypertensive, you can put, but as soon as you start clicking out, they cannot get out of there. And that's the concern. You should do that, of course, you're doing that.
So the same may also apply for SGLT2 inhibitors, because we had all this data from IgA nephropathy. I think at the current EDTA meeting, they present data on focal sclerosis, and here we go with new data.
Oh, I see it.
Yeah.
Yeah. No.
Okay.
Sure. Go ahead.
So, do we know anything specifically for membranous nephropathy when it comes to SGLT2, or is it just the same as for ACE inhibitors?
I would say it's the same. I think when you have a patient with low grade, like IgA nephropathy, right, that's fine. But we're talking about patients who have 1 gram, 2 grams of proteinuria, 3 grams of proteinuria. Then I think it's fine. And I have been using, I keep this paper because every time I write, I have to give the copy to the patient, a prescription, because in the United States, this is very expensive. Insurance company are trying not to pay, whatever. So I give a copy to the patient. But again, on a membranous nephropathy, forget it. If you have a patient with membranous nephropathy or primary FSGS, when we have really proteinuria 10, 12 grams, 15 grams, forget it that a SGLT2 inhibitor is going to really make a major impact on the proteinuria.
It's a good moment to switch to immunosuppressive medication. And I guess here's a major shift in the KDIGO guidelines, and we discussed last week with Dr. Glasak. He also said, with all his experience in nephrology, that potentially membranous nephropathy is a major changer in the last 10 years, thanks again to your works. So how long shall we wait before starting immunosuppressive treatment? And shall we go to rituximab, or which patient should still receive either calcineurin inhibitors or cyclophosphamide?
Well, again, let me rephrase the story. It's not my work. The pioneer work of rituximab was done by Beck. All right. Then I was lucky that because we were doing studies here at Mayo with rituximab in ANCA vasculitis, and that's what with the RAVE trial that was the first that resulted in the first indication for rituximab ANCA vasculitis. And because of my connection with Genentech through the ANCA vasculitis world, when I saw that Beck had that study done, I said, well, what we should do one here in the US. But he was the one who started, all right? So again, we have to, in this day and age, I think you are asking about immunosuppressive therapy. But before I go to immunosuppressive therapy, I think there is also a fundamental thing that I diverge from a lot of people. I do not really believe that that is membranous nephropathy is that 1/3 of the patients go into spontaneous remission, 1/3 go long-term proteinuria, nothing, only 1/3 in diet. I think that the PLA2R positive anti-PLA2R is much less than 30%, probably 10% of the patients. All right, I don't really believe that this is going to go spontaneous remission. But even if that is spontaneous remission, all right, I believe that the quality of life is very important. Like 30 years ago, 40 years ago, there was a group in London, Douglas Black, published that if you have patients with minimal change disease, right, adults with minimal change disease, if you don't do any treatment, all right, about 80% of those patients will go into spontaneous remission. But it takes like 5 years. All right, so 5 years, a lot of patients being, in my view, are being tortured with legs of this size, full of edema. I remember 1 year that was published in one of these studies that we did. I saw a surgeon from London, an orthopedic surgeon who came to Mayo. he had 18 grams of proteinuria with an albumin of 1.8. He couldn't operate he had been on nephrotic syndrome for 18 months. He couldn't operate for the previous year because the surgery required like 6-7 hours standing. He was so edematous that it was impossible. All of this because his doctor in London told him that he was going into spontaneous remission. To me, this is torturing a patient, all right? So the question now, we don't argue about spontaneous remission in minimal changes because we believe that the cost benefit of giving a course of steroids, short course steroids, is much. You give the short course, put in remission, goodbye, all right? It's out. And the reason why we have all this argument about immunosuppression therapy in membranous nephropathy is because the therapies we had until recently were very toxic. We had the Ponticelli regime that you give 9 grams of methylprednisolone plus cyclophosphamide, who can cause leukopenia, infertility, severe infection, diabetes, etc. Now, I'm not here to, I have, of course, I like to do to my patients what I would like, all right? What I like to answer is I would like to do to my patient what I do to myself, all right? And the question is, we need to move of this, which which is the best treatment. It doesn't exist the best treatment in my view. Exists is the best treatment for that individual patient. For example, in the mentor study that we talk about, all right, there were like 75% of the patients that were PLA2R positive. And of course, in this group, the rituximab was superior to cyclosporine, no question about, no doubt. But there was 25% of the patients who were PLA2R negative. Now, if you look at that, it's in the supplement information, you see the proteinuria of those people of the PLA2R was about a mean of 12 grams, but the proteinuria on the PLA2R negative was a mean of 6 grams. And in this group of the PLA2R negative with 6 gram proteinuria, basically, it didn't make really much difference if you treat those patients with rituximab or cyclosporine, right? So what I'm going to say, so if let's say I get a 35 years old woman with PLA2, because what I'm trying to say is there is no patient, I never saw a patient with membranous nephropathy in my life. I never saw it. What I have seen is a 30 years old woman who never had a pregnancy, who is just married, wants to have a baby, and has membranous nephropathy, and has normal kidney function. Or I have seen a 65 years old patient who has membranous nephropathy who had a history of prostate cancer 5 years ago. Or I have seen a 45 years old woman who has membranous nephropathy and is diabetic. Or I have seen another patient who also is membranous nephropathy but had a history of breast cancer 10 years in the past. So, and then you can change and you can put of each one. You can say the first one has a creatinine of 0.9, the second one has a creatinine of 1.8, and the other one has a creatinine of 3, all right? So then you can see that there is no membranous nephropathy patient. Everyone is individual, all right? So if I say a 30 years old woman who is PLA2R negative, who has a proteinuria of 6 grams, to me, this patient may easily be treated with a calcineurin inhibitor because it's likely that they should do very well. And you can do that for a year and a half, and then probably they go into remission, and thank you very much, good. If a patient, on the other hand, comes to me and has creatinine of 2.8, and his PLA2R is through the roof, like 500 or more, all right, and my creatinine of 2.8, I think, although I believe that you repeat the course of rituximab, you may result of that, I don't want to mess around. This patient should be treated more aggressively with prednisone and a cyclophosphamide. All right. Now, to me also, I'm thinking about. I was talking like a couple of weeks ago. I was in Madrid and I was talking to Manuel Praga, having dinner with Praga, and I think with the use of steroids, we need to create a new Ponticelli protocol. Because what I treat those patients, I showed the example to him, those patients that are real patients. I don't give the 9 grams of methylprednisolone. What I do, I just give 1 gram of methylprednisolone day 1. Then I put the patient on 20 milligrams of prednisone, and I give them cyclophosphamide orally according to the creatinine age adjusted, all right? I start at 2 milligrams per kilogram per day oral together with the prednisone, and then adjusting the dose according to age and creatinine. And in these 2 patients that I showed to him, that one has a PLA2R greater than 1500 and a creatinine of 3, and the other has a creatinine of like 3.3 and a PLA2R of like 702. In 2 months of this, 2 months with just 1 gram of methylprednisolone, 20 grams of prednisone, and 2 months of cyclophosphamide, PLA2R was 0. And in this patient, I stopped cyclophosphamide, and both of them are in remission, immunological remission. So we don't need 9 grams of methylprednisolone, and you don't need to give cyclophosphamide like as the Netherlands regime that you give that for a year. You can do it with a short course. Now, if you have a patient that again is a 45 years old man, has PLA2R, has normal kidney function, all right, and has 10 grams of proteinuria and PLA2R is like 80, I think the easiest way is to give rituximab, because you just give 2 grams of rituximab and then you follow the PLA2R. You have to follow the PLA2R. And at 6 months later, you look again. And if PLA2R at that time is 0, good, game over. Just follow this patient. Proteinuria will take 18 to 24 months to go into the nadir, sometimes longer. But then you follow the PLA2R and the protein. If 6 months later, his PLA2R that was started was 120. At 6 months, the PLA2R is 24. Is the B cell 0? Fine. Is the proteinuria that was 12 grams is now 6 grams? We are in the right place. Do nothing. Bring the patient back to follow up in 3 months' time. 3 months' time later, his proteinuria that was 6 now is 7. And the PLA2R that was 24 now became 48, and the B cells that were 0 now are 10. Then you retreat this patient. You give another rituximab. If the other way, at that time, the PLA2R that was 24 now had gone to 12, and the B cells are coming back, but the proteinuria is down to 3 grams. You do nothing. You just continue following. 3 months later, you follow again. The PLA2R now has become 7. And the B cells are 100, but the proteinuria is 1.7. You are in the right, just continue follow. On the other hand, that the PLA2R now has become 48, then you retreat this patient. So you can see that I am giving you 3. So how do you, what is the best? They are all effective. The way is which one, how you apply to one or to the other. The young gal with PLA2R negative, low proteinuria, do perfectly well a calcineurin inhibitor. The patient who has abnormal kidney function, then I think you need. Now, there are other drugs on the market. For example, we published last year or whatever 3 case reports in American Journal of Kidney Disease, the patient with membranous nephropathy, PLA2R that failed rituximab, but responded to a new anti-PLA or anti-B cell that is obinutuzumab, that is produced by Roche, much more powerful anti-CD20 depleter, very impressive. I have other patients that now that also fail rituximab, and you give obinutuzumab. But again, it depends on, we're talking about cost, all right? This is in the United States, which everything is crazy, cost a lot of money. Like this cost about 2 doses, cost about $25,000, all right? Now, in Italy, I was talking the other day with Dan Catron, who is my great collaborator, and I learned a colossal amount of deal with from Dan. And we are talking about the cost. And I said, I talked to Dario Roccatello in Turin. And he tells me that the price of the generic of rituximab in Italy is like 700 euro, 800 euros, all right? And then I said, I'm going to email him now. And I mailed and I copied Sean Bobar in Vancouver and Dan Catra in Toronto. And next day, Dario Roccatello replied, said, he is correct. We just negotiated. He gave the name of this company. And in Italy, the cost of 1 gram is 350 euros. So 2 doses is 700 euros. Then you go, you see, then it becomes, then we are talking another language, all right? Because if you can just for 700 euros or 1,000 euros, you can give there and goodbye, rather than give the patient cyclophosphamide that you have to monitor the white cell count because you give steroids, then you may put him in diabetes or weight gain. Or if you use a calcineurin inhibitor, you monitor the levels and you have to check it. So you see how so it's all, I think you have to, the bottom line is the individualized medicine is what you need to do. And same for glomerular disease, it has become per excellence the drug where we can do individualized medicine to the core, all right? It's the same for membranous nephropathy, it's the same for vasculitis, all right, where you can individualize how you're going to treat those patients.
Maybe one last question on Mentor before we switch to prognosis. So when you designed Mentor, you decided to compare rituximab without steroids, if I got it right, to calcineurin inhibitors, rather short-term, 6 months or so. Why did you compare rituximab to cyclosporine and not to cyclophosphamide? Because of toxicity, or what are your ideas behind it?
So, very good question. You see, when you do a randomized trial, you have to have collaborators, all right? Because especially if it's a rare disease, all right? So we had that meeting of the investigators, all right? So remember, Mentor was we have like 23 sites, all right? But at that time and then we decided that we are going to randomize against Ponticelli or against calcineurin inhibitor, because in North America, in the US, and Canada, the more common use here is calcineurin inhibitors, all right? Is preferential more used than. And the bottom line is that only 2 sites of those 30 that we had that meeting at that time, that was Sharon Adler in UCLA and Lee Heber in Ohio State, they would agree to randomize against Ponticelli. The rest, like Dan Catran, Jerry Appel, they all say, God forbid, we are not going to kill our patients. This is too toxic, whatever. So that is it. This is like I'm going to tell you an anecdote. The first study that I did in rituximab after I saw Beppe study, so I put a study to Genentech to do a pilot study on 15 patients. And I used the same Ramuzi protocol, 1 gram of rituximab on day, 375 milligrams per meter squared on day 1, 7, 14, and 21st. So Genentech review, but at that time, they have just gotten approval for rituximab for the rheumatoid arthritis. And rheumatoid arthritis dosing was 1 gram on day 1 and 1 gram on day 15. So I remember pretty well, I am meeting with Genentech and they said, well, we like your protocol, etc. I think it's a good idea. But we have this just approved for rheumatoid arthritis. So the proposal to use the following. Why don't you get the use instead of the 4 doses, you get rituximab 1 gram on day 1 and 1 gram on day 15, and then we will fund the study. If on the other hand, you don't want to do that and you want to continue with the 375 weekly for 4 doses, we don't fund the study. Which way do you like? Do you prefer? I mean, that is, all right, so that's why the first pilot study was done with 2 doses. The scientificity was economic, all right, because otherwise I would get no funding. So when we did that, I only had 2 sites that will recruit against Ponticelli. So we have to say, well, then is the standard of care. That's the standard of care in North America is to give a calcineurin inhibitor. That's what we're going to do. Then comes the second question. Why 12 months? Because remember, we submit that study. I mean, this is just, if I may continue talking, I will explain something because I think that this is a study when we do Mentor, we designed Mentor. We had done a pilot study with these 15 patients that we gave 1 gram on day 1 or 1 gram on day 15. All right. And we show that 50% of the patients have proteinuria complete or partial remission at 12 months. Then I went, but we then at that time found out that rituximab was being lost in the urine. And that's why why we couldn't have more. All right. So I went to Genentech, and at that time they agreed then to go back to the original protocol to give the 4 doses as Beck had done. And then we recruited 20 patients. The only thing is that we switched the timeline because I had looked at the Ponticelli regime, and you can look at Ponticelli papers. You can see that even Ponticelli, the proteinuria nadir goes down gradually. When you look at his paper that he published after 10 years follow-up, you can see that it takes 2-3 years for the maximum effect. So we said, well, we're going to put the endpoint at 2 years. And we do more pharmacokinetics, more pharmacodynamics, and bingo. When we treat those patients and we look at the endpoint at 2 years, then we got 80% response. But if you look at 12 months, the response was the same. So it's not that 4 doses were more powerful than 2 doses. It was just where you try to look at the time point where you're going to meet. So that's why if you are going to do a study on membranous nephropathy, and the endpoint is proteinuria, you cannot put the endpoint at 6 months or at 12 months because you are going to miss the both unless you have a drug that you believe that is a miraculous drug, all right? So we have to put 18-24 months. So that's why we put that. At the same time, when we have done this too, we have found that Larry Beck and David Salant have found PLA2R. So because I had those samples or those 2 pilot 35 patients in the freezer, I called Dr. Salant and I said, what do you measure anti-PLA2R in response to therapy? And he did. And we published this in JSON. It was the first time demonstration at that time that if you get rid of the antibody, you get rid of the proteinuria. If you don't get rid of the antibody, you don't get rid of the proteinuria. And if you get rid of the antibody and that the antibody reappears, then you relapse. So it was pretty good evidence. So we have done the pharmacodynamics, we have done the pharmacokinetics, and we have a biomarker that is the PLA2R antibody that was all right. So we said that's time to do but of course we need money for that. If we were going to do a study of superiority in a rare disease, we did the calculation that we would need like about 350 patients, which is a colossal amount of money there. But anyway, we calculated, let's do exactly what we did, because again, my experience with ANCA vasculitis in the RAVEN study, that was also a non-inferiority study. Let's do a non-inferiority study just to see if it's non-inferior to calcineurin inhibitor, but it's superior in maintaining long-term remission. But again, a study is a study, all right? So it's not the proof or at the end of the story or the learn of the 10 commandments. It's a study to do something, right? That you have to choose it. And I remember then we got the cost at that time was $10 million to do this. We calculated with 130 patients. And then I said, how are we going to do? So we wrote to the NIH, the National Institute of Health. But before that, I have a private foundation that will say we will give you $2.5 million. Genentech said we're not interested. The patient population is too small. There is no point in doing this. But anyway, so we said, but then the private foundation said we'll give you $2.5 million. With this, Genentech said, oh, well, if a private foundation is interesting, maybe we can give you something. So and then they said, okay, we'll give you $5 million. So I have 7.5. And with this, I went to the NIH. It was review. The committee review said that the study, come on, we're coming from a study that we have a biomarker, a pharmacokinetics, pharmacodynamics, follow-up study 1 year, preliminary data 2 years, the biomarker, and we have 75% of the fund, all right? So in the first study to be done in 30 years in membranous nephropathy in the United States, well, the committee review found the study was good, but the executive part of the NIDDK said, no, we are not going to give you the money because all the monies have to go to the RO1, meaning the zoology, all right, with zoo, which very little to medical translation. That's why from then on, I'm not calling them NIH anymore. To me, they are the National Institute of Animal Health because they're all interested in looking at it. So this was the story of our, so then that's why we have to randomize to cyclosporine. Now, you can argue, of course, in retrospect, that but you stop the cyclosporine after 12 months, you should have continued the cyclosporine longer. Sure, we could have continued cyclosporine longer. But what I like to point out, this was a study, all right? I could argue, therefore, that because a lot of people say, well, but the study, there was a 40% failure in mentor or rituximab. And again, this is because it was a study. We knew that if a patient that's treated with calcineurin inhibitor, that after 6 months of a therapeutical dose, if there is no reduction in proteinuria, this patient is not going to respond to calcineurin inhibitor. Then, because we were doing randomized to other calcineurin inhibitor or rituximab, you have to create an exit because you cannot oblige a patient that you know is not going to respond to continue just because you are going to redose the patient with rituximab 6 months. So we created that business that at 6 months, if the proteinuria reduction was less than 25%, those patients would consider failure and exit the study and then be treated as best medical practice. This resulted that a lot of patients that could have responded at a later stage. Remember, I told you when we did the 2 years study that we gave rituximab and just followed those patients, there was no stopping rules at 6 months. We just follow. When we look at 2 years, 80% were in complete or partial remission. But in mentor, because it was a study, we have to create, it was unethical to, in our view, create patients to remain 12 months of calcineurin if I knew that they are not going to respond, just to benefit of allowing the rituximab to take effect. So that's why you have this 40%, because it was a study. It's not that rituximab has a 60%. Rituximab, if you do that and you do non-oppose, the outcome, I mean, that's not just that. Beck and Ramuzzi showed the same, all right? About 70-something, 72, 73% at 2 years. So it's much higher. But again, study is a study. And the study cannot, a lot of people want to be a study that is going to be the Bible. It's not. A study is a study. And then you want to do another study, you can only get some information. You cannot get everything from a study.
So I'd like just to move on a little bit on the outcome of patients with membranous nephropathy. As you said before, you don't really believe in the 1/3 rule. Do we know why some patients go into spontaneous remission and other ones develop end-stage kidney disease? As you said, there is a little something with the prevalence of the antibodies.
Well, I would say that, yes, I would say that some patients go, but I would say now that we know that how to deal with this patient, whatever, if you catch them early, it's very rare to, of course, it's not non-existent. I see patients that have membranous nephropathy that are resistant to everything. I have patients here that I have thrown everything to them and they still have massive proteinuria, but they are rare, right? This is very rare. This everywhere you have this rarity. The reason why I don't believe in this spontaneous remission of the PLA2R is because mentor already tell you if there was a spontaneous remission, all right? So why they all relapse when you stop? Because it should be a colossal. You you shouldn't have a problem, because in addition to the immunosuppressive therapy, you should have the spontaneous remission. So you'll be fantastic. At 2 years, you should have 60% remission, 30% because of immunosuppression, and the other 30 in the cyclosporin arm. On the other hand, you have 80% relapse. So what is the spontaneous remission? All right. Also, I see patients here, a lot of patients in the PLA2R that I see. A lot of patients, yes, I see they come with low level of PLA2R, and I follow them. All right. But usually what I follow, and sometimes they take 1 year, 18 months, but eventually, boom, the proteinuria goes from like 2 to 10 grams. And this is the majority of those that I see. They have low, if they have low level of PLA2R, the low level proteinuria, I don't do anything. I just follow them. But the majority of the patients that I see, they progress. They don't go the other way around. They go to they have, like he was there and then suddenly went to spontaneous remission. This is the exception. The majority is what they have, at least the ones I see. But this may be regional, all right? It may be because Europeans may see a different, who knows, a genetic background. Again, we go to environmental factor, what is the story? But the majority that I see here, they don't go into spontaneous remission. The majority, they may keep this low level PLA2R, but then instead of going down, they suddenly, boom. I had a patient like not much longer. Again, 60 years old man, whatever, he came, 2 grams of proteinuria, 1 gram. I even was worried about should I biopsy him or not biopsy this. But then one day his 2 grams in like a couple of months became from 2 to 10 grams. And the PLA2R that was 24 had gone like to 80. So I don't see them. But I'm not saying they don't exist. And again, if the patient has low degree proteinuria, like 4 grams, is normal kidney function, there is no hurry treating those patients. You just follow them in this group with conservative therapy, and some of them do very well. You just follow. But this is, in my view, is the minority. At least, maybe because I am a referral center here and I see patients, maybe the other ones are in the community that I don't see. But again, I would give you the story of the mentor. If the spontaneous remission was 30%, then on top of immunosuppressive therapy, the outcome should not be 80% relapse in the cyclosporin arm, isn't it? So something doesn't match.
And you've talked a bit about activity markers. You've mentioned proteinuria, you've mentioned the creatinine, you've mentioned the PLA2R antibodies. Are there any others that we should look at, like activity markers?
Well, I do think that the GFR, I mean the creatinine clearance, I think is
Oh, sorry, of course. Yeah.
I look with the EGFR, etc. And I think that a lot of I think in my view, you should keep the kidney function as best as possible. I like the albumin. I think the albumin is the first thing that goes up. If the patient, even before proteinuria start going up, you look at the serum albumin. If the serum albumin start going up, we are in good in good track, in the right direction. If you treat with rituximab, whatever you want, and 3 months later, 4 months later, the albumin, instead of going up, is going down, that is not a good sign. That is unlikely that your therapy is going to be effective. You know, you are barking. And the other thing, we go to the calcineurin inhibitor, and people are going to say, yes, but you should have used the mentor calcineurin inhibitor longer. Fine. But remember that in the calcineurin inhibitor, the cyclosporin arm, those patients, if you look at that, a year later, the GFR in the rituximab arm, I think they start with a GFR of like 82 or 84. I forgot what was the story. But at 2 years, the eGFR was 100 mL per minute in the rituximab arm. But in the cyclosporin arm, they started with a GFR like 85. And 2 years later, despite not being on calcineurin inhibitor, they have a drop in GFR or like 12 mL, 10 mL. So 1 year of calcium inhibitor was enough to induce nephrotoxicity that was lasting at least 1 year after the drug. So yes, you could do, but what are you doing to the EGFR of those patients? You know, and it's not, it doesn't appear so easily reversible, even after.
Okay. Yeah. Maybe just 2 last questions, if it's okay with you. Let's say we've discovered a patient with anti-PLA2R antibodies who doesn't have any renal manifestation, so it's an incidental finding. Will this patient develop membranous nephropathy in the future? Should we monitor that closely, or what are the risks?
It's a study that came to my mind from not from the study session of the NIH, because the NIH has also the hospital and they also have clinical investigation. So they published maybe 2 or 3 years ago in JSON. And what they did, they managed to get the serum from the veterans, or the army, whatever they have stored that, and they found that some patients may have antibody for years before openly manifest. So if you remember, those patients were without proteinuria, they just have serum because they were giving blood donors, whatever. So, but if you have a patient, let's say, with little proteinuria, which I ordered PLA2R, that's why when we look at a study that we published in KI, whatever, then you can say, well, but they only published on 80 patients, but they did tests for 1,700, because what I told you, I'm doing, everyone comes with proteinuria gets a PLA2R, boom, all right? And but I mean, this is likely to be cheaper in Europe, all right? And the more you use, it becomes cheaper. So, but it's like, if a patient has proteinuria, and I mean, if it's low degree proteinuria, then I would do nothing, but you follow, because what I mentioned, some patients, they have this low degree of the PLA2R for months, or even years. I have, on the other hand, a patient from like Colorado, is a 70 years old lady, whatever. And she has this 20, and I see her because I mark her on my PLA2R 24, 20, 26, and has had for the last couple of years that business. I have done nothing, no treatment, no nothing, because her proteinuria also remain like 2, right? But again, these are, in my view, these are exceptions. But you follow, of course, you have to follow the PLA2R. PLA2R is a fantastic help because you follow this to not only diagnose, but to follow the therapy. If you give whatever you give, in 3 months later, the PLA2R has not moved or has gone up, change therapy.
Okay, thank you. Very last question about renal transplant. What is the chance of recurrence with membranous nephropathy once a patient has had a transplant?
Well, if they are PLA2R, is high. They have a, if PLA2R is positive, they are high. And of course, we published that, and other people published that. So, but now that we know, I mean, a lot of these were retrospective. Now, I think any patient that comes to you and has end-stage renal disease that is going for a transplant and is membranous nephropathy, you have to do PLA2R, either by serum, all right, or you look at the, now I forgot to mention this, but I'm just going to make an advertisement, all right? Remember that here in Mayo, I told you about Sethi, we do a lot of mass spectrometry. So, and I said to you, what are the antigens, and we stain the antigens or the serum, whatever, but in the future, near future, and that's what we try to implement here at Mayo. You get a biopsy, you just do a mass spectrometry, and a mass spectrometry just tell you exactly what they meant. Well, not exactly, because it is some business that we don't know. Despite all these 8, 9 antigens, there is still something there, right? But in the majority, you do a mass spectrometry, and the mass spectrometry is going to tell you if this is PLA2R, is that Thrombosponin, if that is NEL1, in one test. Now remember, if you are going to have a battery of tests, then you have to have 9 slides, or one for the NEL1, one from protocadarin, one from Thrombosponin, one from the mass spectrometry. You just do one sample, and you know everywhere. And the most sensitive, even in patients who have the staining is negative, you get the mass spectrometry, you don't miss it. All right, so you do that. But I got, oh yes. So then the patient is coming from a transplant, but you don't know, well, he had membranous nephropathy, but we don't know what if his PLA2R positive in the past, so you should do the PLA2R. If that patient is PLA2R positive prior to transplantation, then you have to keep an eye. And what we do here at Mayo, well, we transplanted these patients and we follow the PLA2R level. In a lot of them, the induction protocol that we use here with thymoglobulin plus triple therapy with prednisone, CellCept, and tacrolimus, get rid of the antibody. Boom, and then there's nothing, and then thank you very much. But in a small group of patients, the antibody remains. All right, you give your thymoglobulin, and the disease in these patients, you should treat fast. You should use rituximab, all right, at least in our experience. And because if not, if you don't pay attention to that, then suddenly you have patients with full nephrotic, much more difficult, some complication nephrotic. That's how we do. Now, you could argue, say, but well, then why don't you pre-treat those patients before the transplant with rituximab? What I would say is that since a lot of those, like 2/3 of the antibody disappear with the induction protocol anyway, so why are you going to hammer more immunosuppressive in a patient? And you're probably going to over-treat 2/3 of those patients that don't need it, because just the induction and the triple therapy will put the PLA2R to rest. But I suspect that if you prior to transplantation, you have a very high PLA2R level, then again, this is a patient that I would be much closely monitored and much, because we have shown, and it's published here, we can see recurrence up to 30 days. You see the deposits around the kidney.
So one last point, maybe to look into the future and talk very briefly about the new therapeutics that are out there. You already mentioned obinutuzumab, the very potent B-cell depleter. There is belimumab, obviously, and there are some antibodies targeting plasma cells. And then there's this whole other aspect of blocking complement factors. What can we expect in the future, and what do you think is the most promising approach, or is it a combination of all of them?
Well, it's an excellent question. And I think that there's a lot of people that one thing that you didn't mention is plasma exchange, all right? So sure. A lot of people say plasma exchange for that. And I'm not very in the great enthusiasm of this, because remember, membranous nephropathy, to me, is not rapid progressive glomerulonephritis. We are not talking about ANCA-associated vasculitis. We are not talking about anti-GBM disease that you have to run and get rid of the antibody, because hours, days is equal to destruction of the glomeruli and severe renal failure. Membranous nephropathy is a slowly progressive disease. And as I illustrate by the study on the mentor, we got rituximab, the entry creatinine clearance was like, I forgot, all right? I don't know, this is a shame. I mean, one of the investigators of the study doesn't really remember what the entry creatinine, what can I say? You know, I'm getting demented, all right? But it's like saying the clearance was like 85, 88, whatever. But I do remember the clearance that 2 years later, it was 100 mL per minute, all right? And this has been in all the studies, all the pilot studies that we did with rituximab that we published before that. If the patient responds, the GFR improves, all right, and goes to normal. So what is the hurry of, if you go to respond 2 years later down the road, all right, and the hurry that you may risk of much aggressive suppression, like people want to do combination of tacrolimus or plus rituximab, whatever, is that you may use more immunosuppression on the patient. I don't know if the long term is very good. All right. So I think the new anti-CD20 is a much more powerful, and I think it will be a significant advantage because it's still, despite everything that I told you, I said, oh, well, the failure of rituximab is not 60%. Well, it is not 60, it is 80, but it's still 20% fail rituximab. So we need something better to take care of this 20. And I think obinutuzumab is probably a good one. I also told you that there is those patients that I have membranous nephropathy that end up on dialysis despite everything that I know. I mean, putting them on Ponticelli, putting them on calcineurin inhibitor, treating them with rituximab. This group, I believe, is probably have plasma cell disorders, and I think I have great hope, and we are trying to collaborate with a study coming from Germany, from Munich, in fact, using the anti-CD38 antibody. I think this is we just published like a couple of months or whatever, another anti-CD38 antibody in the patients with proliferative glomerulonephritis with monoclonal immune deposit. You got 100% response. This is extremely rare in a disease to get 100%. I only remember once that is erythropoietin, that the first study you gave it in 100% of the patients responded. So anti-CD38, I think is another thing that to be watched. Now, belimumab, I don't believe in belimumab. I tell you why. Because it's like how can I say? It's like a belimumab is. So let's make an example. Rituximab is like a Porsche, all right? Belimumab is like a Beetle, all right? So, and you want to get this done, and you need to go from Frankfurt to Munich. Well, how many days do you have it? Because if you have many days, then take the Beetle, all right? But if you want fast, just get your Porsche, and in a few hours, you boom, you are there, all right? So belimumab, it works, but it's very slow. It's like taking off with a propeller plane, and then the other, all right? So it takes a long. I have a couple of patients, because there is a pilot study published in NDT like a couple of years ago. So I said if that patient had PLA2R, but he got a allergy to rituximab, an allergic reaction, so he relapsed. And he had already been treated with cyclophosphamide in the past. So I said, well, I'm going to give you belimumab. But a year later, he was still like that. So I said, goodbye with this. I mean, this is so. In the complement inhibitors, I have no doubt that they will work. All right. But the question is, what are we going to use? Because it's not a pattern, it doesn't get rid of the antibody. You are controlling the effect of the antibody. And what are we going to use? Eculizumab that costs $700,000 a year, and then you're going to keep these patients, or whatever calcium complement blocker that is going to come into the market is going to come into the hundreds of thousands of dollars. So what's the point of this business? All right. And again, to those who say, well, but maybe you can fast whatever, in fast reduction, the damage, rapid reduction, and I go to the same thing, to the basic. I'm not talking about rapid progressive nephritis. That I need to fast reduction in membranous nephropathy. There is no inflammation. All right. So what are you talking about? So what is the hurry? All right. So if it's a hurry, is at the cost of thousands of dollars, I don't see any benefit on this. But the two that I would like is the new CD20 antibody, and the anti-CD38 is really good.
So thanks a lot. This was really very, very interesting for us, and hopefully also for all our colleagues who will watch this video. And we particularly appreciate all the information you gave us on the background of Mentor, and also all these ideas behind it, and the real world evidence and the limits of evidence from studies and how we can transfer this in clinical nephrology. So we deeply appreciate having the opportunity to talk to you, and we are sure that the novel guidelines to which you contributed will give us some more evidence and some more information. Thanks a lot, and stay protected.
You too. Thank you very much.
Thank you.
Thank you. Thank you. Bye-bye. Thank you. Thank you.